tremendous job. Erin is one of our chief residents, and Erin went to medical school at Albert Einstein. We were fortunate she interviewed with us and decided to come here. She's been an absolute joy to work with and train. And Erin has decided that she is going to be a pediatric neuromuscle doctor like Dr. Rogers. And so Erin is headed to UT Southwest in Dallas to do a fellowship in pediatric neuromuscle disease. And all that we know is that wherever she ends up after that, they are going to be very fortunate because they are going to get a gem of a person. Erin is going to be talking to us about neonatal hypotonia today and was mentored by her mentor, Dr. Rogers. And Dr. Amanda Rogers is the director of our neuromuscle division. And Dr. Rogers came from St. Louis Children's. She was also one of our stellar medical students over here. And we were fortunate that husband and her decided to come back to Louisville, and she has just done a tremendous job for us over here, an award-winning teacher, and just a tremendous faculty member. So I think we are in for a treat today. And Erin McCoy.
Thank you so much. Okay. So I'll be talking about neonatal hypotonia today. This is my baby. I put him up here for a reason, not just to show him off. We have some ambitious objectives for 30 minutes, but we're going to define tone and hypotonia, describe the components of the physical exam for tone, try to talk about strategies of localizing hypotonia and some differential diagnoses that you should consider, discuss some workup of hypotonia, and then talk about some of the more common, especially major and potentially treatable causes that we should be looking out for. So first of all, what is tone? So the definition of tone is the resistance to passive movement. And another way to think of it is the tension that is in your muscle at rest. So your muscle cannot exist in a completely relaxed or completely contracted state. Even if you think you're relaxing your arm, there is always some degree of contraction in your muscle, and that's protective against injury. So the idea is that if you overstretch your muscle, there are mechanisms to bring that muscle back to prevent overstretching and injury. So you can sort of split tone into two different categories. Your first category being your postural tone, so your axial or the tone in your axial or truncal muscles. This helps you just maintain your posture and balance and resistance to gravity. And then what's called your phasic tone, which more has to do with tone in your extremities, so it's also called appendicular or peripheral tone. Your tone is dynamic, so it's not just a static level of tone all the time. It can increase when you're stressed and upset, decline during sleep, or due to pharmacologic interventions, drugs, and sedatives. So hypotonia is decreased resistance to passive movement, so lower than expected tension in your muscles at rest. And it's important to recognize that hypotonia is a symptom and not a diagnosis in itself. It can be due to central, so CNS or peripheral PNS causes. So we'll talk more about that later. And then just briefly touching on the physiology of how tone is generated. Let's see, this is the thing here. So you have what's called your muscle spindle that lives sort of in between your muscle fibers here, and this is a group of sensory neurons. It is constantly sending signals to your spinal cord, so it's tonically active, and its job is to sense the muscle length, the muscle stretch, and it's constantly sending signals to monitor how long your muscle is and what sort of level of contraction it needs to be at. So your spinal cord takes those signals, the synapse in the anterior horn, sends it back to your muscle, and then creates this level of tension. So this is the peripheral mechanism, so you don't need your brain to do any of this. Actually, most hypotonia comes from central CNS insults or problems, and so this pathway might be completely functional, but you also have some degree of brain coordination of this pathway as well. And so if you were in Dr. Barton's lecture, he talked about a lot about the mechanism of spasticity. So if you have your cortex is kind of constantly inhibiting this pathway so that you're not just producing so much tone in spasticity. So we think a lot about CNS insults causing a decrease in the inhibition of this pathway, essentially overactivation of this pathway, but CNS insults can also cause the reverse. And it's less well understood about how that happens, but definitely still a factor. So hypotonia, central or peripheral causes, and we'll see that it's actually more often central. So other definitions that are important to consider, if hypotonia is decreased resistance to passive movement, you have to distinguish that from weakness. So weakness is a decrease in the power that you're able to generate with your muscle. So it's more of an active process than a passive process. Infants that are weak will often be hypotonic, but you can be hypotonic and not be weak. So you can have full strength of your muscle when you're activating it, but passively you tend to have lower muscle tone. Hyperextensibility is also an important thing that can go along with hypotonia. This is just an abnormal increase in the range of your joint movement. So both of these can accompany hypotonia but are different things, and you should assess for all of these things in your neurologic exam. So moving on to the tone exam, you always have to put tone into a context of your gestational age and the state that the child is in. So you should expect some degree of hypotonia in prematurity, and tone is even used in the Ballard score as a measure of how mature you are. So if you're even trying to estimate a gestational age, your tone is going to give you a lot of clues there. So the lower your gestational age, the more hypotonic a baby will be. Again, sleep, sedation, you should expect hypotonia in. So when you're examining tone, you always, in the neurologic exam in general, which I know we've gone over this morning, but observation is so important. So even something like tone, where you would think it's mostly based on movement and how you're feeling the muscles, you can see a lot just by looking at a baby. So you want to look at them while they're supine. A normal, and this is when I list all the normal sort of findings, this is in a newborn. So a normal term newborn should have flexion of the extremities. They should be sort of closely adducted to the trunk here. It's also a good time to just assess for the spontaneous movement as well. So my baby has a blurry hand here because he's moving his hand around, he's lifting his hand anti-gravity, so you want to see, can they move their arms and legs symmetrically, can they move anti-gravity, and so you always want to assess their movements as well. Abnormal resting posture, in profoundly hypotonic babies, you'll see this sort of frog-legged posture. So their hips will be flexed, their legs will be externally rotated, their thighs will sort of just rest on the table. Their arms can either kind of be back in this W shape and resting behind them, or just sort of extended flaccidly. Their head might loll to one side as, instead of just kind of staying midline most of the time. So you also want to move them onto their stomachs and look at them in the prone position. Normal newborns will be able to just lift their head enough to be able to kind of move their head side to side. That's really all we expect in a newborn baby. You're not going to see a whole lot of head control there. They should keep their hips flexed and their bottoms can get elevated. If you move their arms behind them, they should be able to kind of move them back up underneath them. And then you want to passively move the arms and legs around. So the examiner's moving the arms all around, crossing them. You want to do this in, if possible, a nice, awake, relaxed state, not when they're screaming and not when they're dead asleep, because you really want to assess their tone at like their good normal state. So you want to move each extremity around, rotate around the joints. And this is really based on your feel. So you have to feel a lot of normal tone infants to really know when you're feeling too little or too much tone. And so some maneuvers that you can use specifically, the scarf sign, you take the baby's arm, move it across their chest. The elbow in a newborn should come right about to the mid-clavicle. It shouldn't go past the sternum. It shouldn't wrap around the whole body like a scarf. And so if you are seeing that wrap around, you're seeing some appendicular hypotonia. Newborns you should have some resistance once you get the foot to about the chest or the shoulder. If you're able to get it to the ear and past, you may be seeing some hypotonia. But older babies are a little more flexible. So my son's 6 months old and I can get both his feet way back here. So that's okay. Your traction response is one of your more sensitive maneuvers. It looks a little mean sometimes, but you sort of just take the baby by their arms, pull them up from sitting, and he's struggling a little bit. He has some head lag. Once they're sitting, your head so when you're pulling up, your head should stay relatively midline to your body as you're moving. It's okay to have a little bit of head lag in the first couple weeks, but this baby actually has some significant head lag. Once he gets to sitting, though, he is able to kind of get his head up to midline and keep it there for a little bit, and then it should kind of drop forward. Your newborn doesn't have the head control to keep it there the whole time. And then when you take the baby and hold it under the chest, he should be able to keep his head in the same plane as his body. The back can kind of curve, but it shouldn't form this complete U shape like it is in the bottom. So this baby's just flopping right over your hand. He should keep his kind of hips and knees flexed, whereas the baby on the bottom is just kind of letting them dangle. Vertical suspension is when you hold the baby upright underneath both arms. You should feel some resistance. You should be able to just hold the baby instead of having to move your hands around and adjust and hold on to like a slippery fish that's just going to slip right out of your hands. So if the baby has enough shoulder girdle strength, they should just be able to keep themselves right on top of your hands. And all these videos are from the University of Utah website, and they go over the neurologic exam from premature infants to 2-year-olds with all these videos, so they're a really great resource. And the next most important step in hypotonia when you're thinking about what do you do next is trying to localize the lesion. Unfortunately, hypotonia is kind of complicated. It can kind of happen due to problems in any part of the nervous system. So brain, basal ganglia, brainstem, cerebellum, spinal cord, all the way down to your peripheral nervous system, your motor neuron, the peripheral nerve, muscle, neuromuscular junction. So one strategy is to just start to figure out, can I just determine, is this more likely to be a central lesion or a peripheral lesion? But also you should always consider systemic illness. So not a primary neurologic cause, but something going on with the baby. If you're seeing a just diffusely hypotonic baby, you could consider them to be septic, until proven otherwise. So you can have profound hypotonia and not have a primarily neurologic problem. So hypotonia is due to central causes in the majority of the cases, so about 60 to 80% of the time. And then peripheral nervous system, just isolated to the PNS, will be about 15 to 30% of cases. So when you're doing your evaluation of a hypotonic baby, you want to think about different factors in the history. So prenatally, thinking about their fetal movements in utero. So these are questions you want to ask the patient or the mom or family, or look in the chart. Any history of polyhydramnios, exposure to toxins, infections, obviously family histories, abnormal genetic screens, and then parental consanguinity. Perinatal and postnatal factors that are important to know. Anything that is making you think that there was some sort of traumatic birth process. So your APGAR scores, any delivery complications, respiratory distress around delivery. It's important also to note the timing of onset of when the hypotonia develops. So is it right from birth, the baby was floppy, or was the baby normal, and then 12 to 24 hours later we start noticing that it's floppy? And if it's around the time of feeding, you should think about inborn errors of metabolism, because that's really when those start to become symptomatic. And then obviously systemic signs of illness and medications the baby's on. So things to think about in the family history, the age of the parents, any possibility that they're related, history of infant deaths or spontaneous abortions, any history of known neuromuscular disease in the family. And then with mom, some things that you may not think to ask. Mom may not have a diagnosed neuromuscular problem, but if you ask her, do you have any history of muscle weakness or double vision or ptosis, sometimes you can see features in mom that are sort of pointing to neuromuscular illness. And so I'll go over kind of those like more dysmorphic features. And then when you're examining a baby with hypotonia, just like with the tone exam, you want to look for various other things on exam. Dysmorphic features, their head size, any signs of hepatosplenomegaly to point you towards metabolic disease. And then some of the other signs of neuromuscular disease that I mentioned, a high arched palate, a myopathic or myotonic face, which has this distinct look, which I'll show some pictures. They tend to have a long face, and then temporal wasting, so the actual atrophy of the temporalis muscles. Their lower face tends to be kind of slack, so they may just keep their mouth open all the time, and then they have this tented upper lip. Some babies will come out with hip dislocations, joint contractures, and then just looking at their respiratory effort. And then on the neurologic exam, definitely want to pay attention to any signs of encephalopathy, because that is going to point you towards a central cause of hypotonia. If you have an isolated peripheral cause, you shouldn't have encephalopathy, because you're just affecting your nerve, your muscle, so you shouldn't have any CNS, usually, findings. And then you want to look for ptosis, ophthalmoparesis, so weakness of those eyelid elevation muscles or restricted extraocular movements. This can be hard in the NICU to get babies to open their eyes and to really see, like, do you have ptosis or do you just not open your eyes? Any poor suck, cry, trying to get a sense of their strength and their movements, keeping an eye out for fasciculations. And then reflexes are helpful to localize. So if you have absent or diminished reflexes, that is going to localize to the lower motor neuron, so the peripheral nervous system. And then normal to brisk should usually localize to the central nervous system. So this is an example of like a myopathic or myotonic face. This is a mom and a baby. They both have myotonic dystrophy. So you can see mom has this temporal wasting. They sort of have a long face. The baby keeps his mouth open and he has this tented upper lip, like a cupid's bow almost. And this is a high arched palate, so you have to get in with a tongue depressor and look at the top of their mouth. And then this is a baby with congenital joint contractures. And he looks a little miffed about having his picture taken. So, these slides are probably the most, I think the most important of my presentation. But when we're thinking about central hypotonia, again, this is the most common reason to be hypotonic. And the pathophysiology is related to inadequate brain control of your motor pathways. And so we'll go over this more in detail. But things that you are looking for in your exam to point you towards a central cause, it's going to be any encephalopathy, dysmorphic features, normal or brisk deep tendon reflexes or clonus, and just the pattern of hypotonia. These babies tend to have more axial rather than appendicular hypotonia. So I just kind of highlighted the things here that that sort of point you towards more central nervous system causes. And then with peripheral hypotonia, the pathophysiology is broad, but it's any process that affects the peripheral nervous system, from the anterior horn cell, the nerve, the neuromuscular junction, to the muscle. So on your history, these are babies that may have had pretty normal pregnancy and birth courses. You want to be on the lookout for those maternal neuromuscular symptoms and family history of symptoms. On exam, they may have a normal mental status. They will usually have more prominent weakness associated with their hypotonia. You can see absent or diminished deep tendon reflexes, but they can also be normal. Joint contractures, fasciculations, atrophy points towards the lower motor neuron as well. And then these are some of the historical factors that point you more towards peripheral hypotonia. So then how do you localize after that? This chart I like because it gives you a few different clues. So if you're seeing a problem of the anterior horn cell, you're going to have weakness, you're going to have absent reflexes usually. If you're seeing a problem of the nerve, you're going to have weakness and wasting and decreased reflexes. If you're seeing a neuromuscular junction problem, you should look for involvement of your face muscles. And you may not have generalized weakness. And then muscle problems can be pretty variable, but weakness, decreased or normal reflexes, fasciculations, and contractures. So when you're seeing a baby that you think has possibly a central cause of their hypotonia, anytime you're worried about anything in the central nervous system, a good first step is brain imaging. So MRI of the brain, head ultrasounds, MRS. We've gone over that a lot today. EEG if you're worried about seizures. There's various types of genetic testing based on sort of your exam and your history, what you're trying to target. And we'll go over some more of that. And then metabolic testing, so screening for the common metabolic disorders with labs. And then in general, if you're thinking more of a peripheral cause for hypotonia, your workup could involve a CK level. You want to rule out congenital hypothyroidism with thyroid function testing. It's important to remember that a lot of babies with muscle problems especially will have cardiomyopathy like even at birth, and so you should look at the heart. EMG and nerve conduction study is something that we can do in the NICU as well. Less commonly nerve or muscle biopsy because we have now a lot of genetic testing that we can do, but it can still also be done. Despite all of these tests, still half of patients are diagnosed or at least given a correct presumptive diagnosis just based on the history in the exam. So this is a pretty busy slide, but this is just kind of going over a differential for central hypotonia, and the more common things that we see, the prevalence is sort of here in the red, so acute CNS insult, so HIE or stroke constitutes about 20% of patients, and a big chunk, 30%, will have some sort of genetic or chromosomal abnormality. 13% or so will have a brain structural problem, and then less commonly 3% will have metabolic disease. And then for peripheral causes, again, they are in general less common. So, half to 2% or so for most things. And then a big chunk here is 13% of patients we will just not know. So going over some of the more common chromosomal or genetic issues that we see with hypotonia. Down syndrome is the most common chromosomal abnormality causing any developmental disability. So you will see hypotonia, intellectual disability, cardiac defects, and more. All of these basically are genetic problems that cause varying levels of hypotonia, intellectual disability, and have some characteristic dysmorphic features. So I won't go into a lot of depth about each of them. Prader-Willi will see more profound hypotonia in the neonatal period, also intellectual disability, hypogonadism, short stature. Initially, they will have feeding problems and failure to thrive, and then eventually obesity. Fragile X syndrome is another one that can have more mild hypotonia, but also intellectual disability and autism. And these are all sort of different etiologies. Down syndrome, obviously, is trisomy 21. Prader-Willi is a deletion on chromosome 15 that's either paternally inherited or the result of uniparental disomy, so something just inherited from mom. And then Fragile X syndrome is a trinucleotide repeat expansion. So SMA is a big hot diagnosis because it is potentially treatable, so it's something to definitely not miss. So spinal muscular atrophy is a heterogeneous group of disorders, but it's basically a defect in your programmed cell death. So essentially the anterior horn cells, which are the main motor cell bodies in your spinal cord, gradually die off. In the classic form, it's an autosomal recessive condition. It's associated with 5q13 mutations. And so you have this survival motor neuron gene that makes your survival motor neuron protein. And so if you take out both copies of SMN1, you don't make any of this functional protein. But everyone usually has some copies of SMN2, which is like a rescue gene. It makes about 10% functional protein. So the more copies you have of SMN2, the better your prognosis, because you're at least able to make some functional protein. So used to, we classified SMA based on the when you presented. So you could present in the prenatal period with decreased fetal movements, and these patients were classically called type 0 SMA. They were very severe. They had severe weakness and hypotonia on birth and respiratory failure, and tended to die by about a month old. Type 1 SMA would be the most common type. These patients have 2 or 3 copies of SMN2, and they would present usually before 6 months of age with hypotonia, areflexia, poor feeding, respiratory weakness, and like normal mental status, normal cognition. Classically, they would die by 2 or 3 years old because of respiratory complications. And so now we have disease-modifying therapies, so we can treat these patients. So we should consider this a neuromuscular emergency. Luckily, it's on the newborn screen in most states, and in Kentucky and Indiana. So that's how we get a lot of SMA diagnoses, is through newborn screening. So this is a baby with SMA, and this is just a looping GIF. But he has several features here that are of note. So he has this sort of frog-legged posture. It's a little hard to see the legs, but they're sort of just resting there, not doing much. He has a very abnormal pattern of respiration, so he's using a lot of accessory muscles and has this like bell-shaped chest. And he looks pretty alert. And Dr. Rogers had this video, and she commented that he even kind of looks like he knows something is wrong. Like he's kind of freaking out a little bit. So this is an example of a baby with SMA. So moving on from the anterior horn cell to the neuromuscular junction, these are less common, but still interesting and good to have in your differential. So moms who have myasthenia gravis, and sometimes moms that are not diagnosed with myasthenia gravis, can transfer their acetylcholine receptor antibodies through the placenta to the baby. So these babies will present with usually generalized hypotonia, difficulty feeding, weak cry, and then a big clue is they might have ptosis and facial involvement. This can come on from hours to 2 days postnatally and lasts an average of 2 or 3 weeks. There is not a specific treatment other than supportive care, but these babies do completely resolve and go on to be normal because they don't have myasthenia gravis. They have antibodies from mom. So this is the type of baby that's important to ask mom about any symptoms that she might have if she doesn't know that she has myasthenia gravis diagnosis. And then congenital myasthenic syndromes are similar, but they're a pretty heterogeneous group. They can be pre or post-synaptic issues in neuromuscular transmission. They can present in infancy, but really all throughout childhood, and the degree of their hypotonia and ptosis and eye muscle involvement and other symptoms can be pretty variable. So they're challenging to diagnose because they have a lot of fluctuating symptoms. So you have to have a pretty high clinical suspicion and be thinking about this diagnosis. And so when we're looking at any neuromuscular junction disorder, the diagnosis is going to be mostly through your clinical suspicion and through genetic testing. EMG and nerve conduction study, if you do repetitive nerve stimulation, can be helpful. And so since you have the hallmark of neuromuscular junction weakness is that you have fatigable weakness. So the more times you do something, the weaker and weaker you get. So when you're stimulating on a nerve conduction, you see a lower and lower response every time. And then another neuromuscular junction disorder is botulism. This won't be present at birth, but can happen very early in life, so even as young as a week old, up to about a year. And so this occurs due to exposure to Clostridium botulinum spores, and you classically hear about this in babies that have had honey, so that's why we don't give babies honey under 12 months. But actually, more commonly, you get exposure from the soil, so walking outside with the baby or on the construction site, or there's construction happening in the home, anywhere where there's like soil turnover and the spores get into the air. So the botulinum toxin targets this snare complex, and so this is a complex that's sort of holding all the acetylcholine in it. It has to bind to the presynaptic membrane and release the acetylcholine, and so the toxin binds to the snare complex and prevents it from releasing, essentially. And so when you have a baby with botulism, you may see them come in and parents will say that they've had symptoms for a few days now of especially constipation, poor feeding, lethargy. They've just started looking really weird and really sick, and then they have this pretty fast acute decline. They get hypotonic, they get weak, lose their reflexes. On exam you can see pupillary dilatation, bulbar weakness, and then a significant amount of time respiratory failure. So it can be fatal if not managed acutely. So you have to have a high clinical suspicion for this as well, and it's diagnosed really based on your exam. There is testing for botulinum toxin, and it takes weeks to come back, so you should not delay treatment for botulism if you think that that is the diagnosis. You can do EMG and nerve conduction studies to help you with the diagnosis, but again, you should treat if you have suspicion. There is botulism immune globulin. The earlier you give it, the better the outcomes, and really beyond that, it's just supportive care. Most babies who get through the acute period tend to have a complete recovery. And then muscle problems. Congenital myotonic dystrophy is an interesting problem. It's an autosomal dominant, another trinucleotide repeat expansion. And this is an example of something that exhibits anticipation. So in each generation, the problem gets worse because the repeats in the gene expand. And so in the congenital form, you have more than 1,000 CTG repeats in this gene, DMPK1. Babies with congenital myotonic dystrophy tend to have pretty profound hypotonia at birth, facial weakness again, poor feeding. They may have joint contractures at birth as well, and respiratory failure. Adults and older people with myotonic dystrophy have cardiac conduction abnormalities. That's less common at birth, but they can more commonly have pulmonary hypertension in the neonatal period. And like I said, they tend to have this characteristic face, this slack lower face, the tinted upper lip. And so the diagnosis, again, clinical and based on your exam, you should send genetic testing for these babies, and you can consider EMG as well. And hopefully there's a family history that you can also be aware of. And then congenital myopathies are a pretty also variable group that are caused by many different gene mutations, and interestingly, mutations that can cause many different types of myopathies. So like this RYR1 mutation can cause lots of different types. They were classified based on their histology in the past, but now we're doing a lot more genetic testing, and so we found these gene mutations. And so they tend to be hypotonic at birth. They tend to be weak. They also tend to have facial weakness. You can diagnose these based on a CK level, which actually can be normal or just only mildly elevated. Genetic testing is really the big thing here, EMG as well. And then if you don't find anything on those tests, you can move to muscle biopsy, which used to be the first line test, but now we have easier things that we can do. And then another disease that deserves sort of mention, glycogen storage disorder type 2 or Pompe disease. This is a lysosomal enzyme deficiency in alpha-glucosidase. And so actually it's sort of a mixed picture between central and peripheral hypotonia, because you get glycogen deposition in your brain and spinal cord and muscles, so it's kind of everywhere. In the infantile form, you can have hypotonia present at birth, but it's usually in that sort of second postnatal month. So babies will often be profoundly hypotonic, and then importantly, they may present with congestive heart failure from cardiomyopathy, and it's hypertrophic cardiomyopathy, feeding difficulties, respiratory failure. So if you're seeing a baby with hypotonia and heart problems, you should think about Pompe disease. You can diagnose it with enzyme levels. You can measure the level of alpha glucosidase and do genetic testing as well. And then there is enzyme replacement therapy available, so there is some treatment. The prognosis still isn't super great. So in summary, hypotonia can be a manifestation of just systemic illness or dysfunction of any level of the nervous system. Your history and your physical exam are going to be the most important steps in your diagnosis. You should always do a tone exam on any neonate, and then think about when you're ordering tests and trying to figure out the problem, localizing it, at least trying to localize central versus peripheral. And then you should try to pay some special attention to some of the conditions that I mentioned, especially the ones that have some early treatment, because the earlier you diagnose it, the better your outcomes. So these are my references. And thank you to Dr. Rogers, Dr. Lacodia, and Dr. Means.